Hello, and welcome to the webinar. My name is Sarah Knopf, and I will be acting as moderator and host for today's webinar entitled HCH Quality Leaders, Key Practices and Improvement Strategies. This is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of Special Population Health. This session is being recorded. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. To the right of the presentation slide, there is a chat box for participant questions and technical issues. Please type your questions into the chat box at any time during the presentation. A select number of questions will be answered at the end. The PowerPoint presentation and the recording of this webinar will be posted on our website at www.nhchc.org within 72 hours. Before we get started, I would like to introduce today's presenters. As I said, my name is Sarah Knopf. I will be the first presenter as a research assistant at the National HCH Council. I have worked for just under a year on the Council's research staff, coordinating a study on veterans, contributing to a paper with the Kaiser Commission on Medicaid and the uninsured, and leading this Quality Leaders case study. Our second presenter is Carol Blank. Carol has worked at RiverStone Health for 18 years in public health in the clinical division. She has been the manager of a community health center clinic in the Healthcare for the Homeless program for 3 years. Our final presenter is Marie Wisely. Marie is the Director of Quality and Clinical Services for Community Healthcare, Inc. In this position, she is responsible for the development and implementation of the Quality Improvement Program, which includes the implementation of an organization-wide electronic health record, patient-centered medical home certification efforts, patient safety, and infection control programs. In addition, she is responsible for leading the nursing staff and coordinating compliance efforts with outside regulatory and accrediting agencies. She actively consults with community health centers to begin or improve their quality programs. I would like to thank both Carol and Marie for contributing to today's webinar. Here is an overview of our presentation today. For the first portion, I'm going to briefly discuss the Council's Quality Leaders case study, including our purpose and methods used to identify HCH quality leaders. For the second part of the webinar, we will hear from 2 of the quality leaders profiled in the case study. Carol Blank of RiverStone Health will share her experiences managing an HCH program within a public health department, including some key quality improvement projects that RiverStone Health has successfully completed. Next, Marie Wisely, Director of Quality and Clinical Services at Community Healthcare, will provide a comprehensive overview of their quality department, health priorities, performance improvement program, and data management plans. And finally, we will conclude with a Q&A session. So now I'd like to provide some project background on why and how we put this Quality Leaders case study together. We know that HCH grantees are continually seeking to deliver the highest quality of care to their patients. However, the debate of productivity versus quality is an ongoing point of contention. Quality goals often conflict with productivity goals. However, with no annual productivity requirements from HRSA, grantees are encouraged to focus more energy on quality improvement, or QI, without the burden of productivity pressures. Currently, not enough is known about what operational practices and improvement strategies drive quality outcomes in the HCH field. This topic, which has often been referred to as the study of high performers, has been explored in many other healthcare settings, even community health centers, but not yet among HCH grantees. Okay, so to develop a better understanding of what strategies work in this uniquely challenging setting, the National HCH Council conducted a case study on HCH quality leaders, meaning grantees that have achieved the highest quality outcomes in their field. Through in-depth interviews, the case study identified key operational practices and QI strategies that have contributed to quality of care successes among the quality leaders. By reviewing the performance outcomes and practices of high-performing health centers, HCH grantees can benchmark themselves against the quality leaders as a way to find areas for improvement and strategies for getting there. So I'm going to briefly discuss our case studies methods. In order to identify the top 10 HCH quality leaders, we calculated hypertension and diabetes control measures for all HCH grantees using the 2010 Uniform Data System. These measures were drawn from HRSA's clinical performance measures. Of the top 10 scoring HCH grantees, 4 agreed to be interviewed for the case study. These included Community Healthcare, Inc., located in the bi-state region surrounding Davenport, Iowa, RiverStone Health, located in Billings, Montana, Harbor Homes, Inc., located in Nashville, New Hampshire, and finally, Care for the Homeless, located in New York City. To explore the organizational practices of these 4 quality leaders, relevant staff persons were interviewed, including medical directors, providers, administrators, and quality and data managers. In addition to obtaining an organizational overview, the interview also incorporated elements of the patient-centered medical home and HCH models. So now that we have discussed the case study's background and methods, I'm going to turn it over to our next speaker, Carol Blank. She is manager of RiverStone Health's Community Health Center Clinic and HCH program. Carol is going to discuss what key practices and improvement strategies have contributed to RiverStone's exceptional quality of care. Carol?
Thank you, Sarah. I'm very honored to be asked to participate in the webinar, and honestly, I'm really proud of our HCH program, so I'd love to visit with anybody who's interested about our HCH program. Again, I'm Carol Blank. I'm the manager of the Community Health Center Clinic and the Healthcare for the Homeless program here at Billings, Montana. Excuse me. We're very fortunate to be part of a large organization called RiverStone Health. RiverStone Health's mission is to improve life, health, and safety. It's a large umbrella organization. Some of the programs that we have in this organization, along with the Healthcare for the Homeless, public health, which is a huge asset for us. Their assistance with population health, the communicable diseases, if there's a norovirus outbreak, TB problems, immunizations, they're just across the hall and just absolutely a great resource for us. We also have a dental clinic here, which you can imagine is a great resource for all the patients we serve in our clinic and our Healthcare for the Homeless programs. We also house the Montana Family Medical Residency. It's a 3-year residency for family practice docs. High percentage of them stay here in Montana. We train them in Montana, and they stay in Montana, which is awesome. We need those doctors in our rural areas. And it allows us to have a lot of providers, and then we also have just a lot of expertise, a lot of people who are willing to work together as a big team to provide the best care for our patients. Maternal child health and WIC is a great resource for our patients, home health and hospice, and then the Community Health Center Clinic. Our clinic, we have 39 providers, including the residents, mid-levels, and then our physicians. We have behavioral health integration in our main clinic, and then we also do have an electronic health record. The reason I mention those things is because everything that's basically available in the clinic is also available to our Healthcare for the Homeless program. We're very fortunate to be integrated. It helps us have a lot more resources for our patients. We are presently applying for PCMH recognition, which I think is awesome. I think it's one of the reasons we have made such good improvements in our program, and just gives us a great path to follow for patient care excellence. Our HCH program started in 1993, and our staffing is we do have a nurse that staffs all clinics. We have 2 different administrative assistants that job share and staff all the clinics. We have an outreach worker. Our outreach worker is all over Billings and the surrounding area. He spends time down at the mission. He also spends time out in the man camps down by the river outside of Billings here, just anywhere where we might find somebody that could use our services. We also have a case manager who spends a lot of time in various other community resources assisting our HCH patients, for example, if they end up being hospitalized, and he's up there to help them out and make a good plan. We have a licensed addiction counselor. We also have a mental health therapist. Both of those behavioral health providers are part of the bigger behavioral health team in the Community Health Center clinic. They are specifically part of the Healthcare for the Homeless program, but you can imagine how we overlap, and so they're available here in the clinic and then also at all those sites. They also have been very proactive in starting some great groups for our patients. One of the most recent ones is our mental health therapist has started a homeless to house group. They get together, they make lunch together, and then they talk about some of those practical things that skills they need to learn to be able to keep that housing and to help them just learn some of the skills they need. Our clinic locations, we are located at the Women and Family Shelter here in Billings. We are there 2 afternoons a week. The Men's Rescue Mission, we're there 3 mornings a week. The Hub, which is kind of a drop-in day area to connect with resources to our mental health center, and we are there 1 afternoon a week. And then also the main clinic. A couple years ago, we just really worked to make sure that our population knew that they could come to any of those sites, but they could also come to the main clinic, and they were welcomed here, and our access that I'll talk about made it really easy for them to come to the main clinic and be seen for care here. Our program, I think some of the strengths of our program with our staff is that we have low turnover and a lot of longevity. We just have had staff that has stayed here, and they're very passionate about this program. They love the population they work with, and it just helps. Our population gets to know them, know their face, and trust them, and they just do a great job. See a picture here. Here's 2 of our staff workers. That's actually one of our administrative assistants, and then also our case manager. And they were participating in, I think it was the Veteran Stand Down event is the one they're at there. Hooking people up with services. We provide as many giveaways as we can, things that we know they need. They may be getting brand new boots. We make sure they have Band-Aids for those heels for brand new boots. These guys know exactly what their population needs, and they'll find it for them. We are, as I said, applying for a patient-centered medical home. All the steps that we're taking for that application and that plan and that path we'll follow crosses over right to HCH. It's throughout the entire program, the dental practice, the main clinic, and then our outlying clinics, and then also the HCH. Some of the services offered, we are a family practice clinic, and so that's birth to death, all ages. We also have digital x-rays and a rad tech during all clinic times, and then a full lab, plus we do the ClearWave labs. We offer dental care we budget every year for some dental care for our healthcare for the homeless patients. That has proven to be such a huge need for them, so that we help them with that. We have medication financial assistance. There are many medications on our formulary that we can pay for our HCH patients, and then there are some mental health if they have other resources that perhaps they just need help with co-payment. Excuse me. I think our access for our Healthcare for the Homeless program is probably one of the most important things we do that really works well for our population. They can walk in for care at both shelters and the Hub. They just come in and sign up, and they get taken care of at the time, no appointments necessary. Now, at the main clinic, we of course do take appointments, but we have opened up our access at that main clinic. You can call and you can make an appointment in a month. If you're a new patient or established patient, we're 30 to 35 days out on those appointments, which is pretty good. We have some appointments that we have set aside every morning called Today appointments, and those usually are gone by 10:30 or 11 o'clock in the morning. But that's someone who gets up today, needs it, and maybe has an acute need, and wants a scheduled appointment, but wants it for today. And then we also do a lot of walk-in care. The walk-in care, we always have a no-show rate, but the walk-in care, we have them come in, we have a nurse triage them to make sure we know what they're there for, and then they get put into appointments where maybe somebody has canceled or no-showed for that appointment. Now, I have to say that since we started doing that, that was a big project in the main clinic. We started looking at how that affected our HCH patients. And for the patients that would come here to this main clinic, rather than go to those shelter sites, it dropped their no-show rate from 17 to 13%. So that walk-in care has proven to be really, really important for them in our clinic setting also, not just those the shelter sites. We also work really hard on having team-based care centering around the patients and their needs. We work really hard to make sure that we have the same providers out at our healthcare for the clinic. And I didn't mention that on staff. I apologize, but we, of course, always have a provider at those clinics. If they can see, whether it's in the main clinic or healthcare for the homeless, if they can see that same provider, they're going to build up that trust and confidence, and then they come back and they follow through on their care better. We also make sure that we have the same nurse, the same support staff, same behavioral health staff. Really, really try to make sure that they're seeing familiar faces when they come into any of those clinic sites. We huddle every day before every single clinic, and then the Healthcare for the Homeless program huddles has a weekly huddle where they get together outside of clinic time just to discuss and make sure everybody's on the same page and see what we can do to better take care of our patients. I wanted to give you some examples of quality improvement that we're doing through the Healthcare for the Homeless program here in Billings. I think we all, in this line of work, we're always working to do a better job. We do things every day that probably are small quality improvements and maybe don't recognize them, but there's a lot of things that are going on. We try to always identify our most important needs, and what we're working on right now is increasing our outreach to our community's homeless population. We believe that we're serving very well the population that is in the shelters, at the Men's Rescue Mission or the Women and Family Shelter, the homeless person on the street. But we do believe that there's a population of homeless by definition that may not see themselves as homeless. They may not relate to that. They may not be part of the shelter system, and we're trying to reach out to them. To do that, we developed a poster. It's very eye-catching. It's kind of like if you've seen graffiti art, it kind of just has statements, and what they are is it's the definition of what it means to be homeless for Healthcare for the Homeless, to catch their attention, and then where to call for help. We've had great luck with that. Our community partners have been really good about posting that information for us. We did have a brochure made up for Healthcare for the Homeless, and it's a great brochure, and it's done its job, I think, better with community resources. What we found out, and I'll show you in a minute, a picture of our resource map, that is the information that our population asks for, relies on. That's what's really working for us to get that information. They're not so much into the brochures, but they love the map and all the information that it gives to them. We work really hard to participate in area homeless events. Project Connect, the Veteran Stand Down are two examples. If there's something going on in the Billings area that our homeless population is going to attend, we try to be there too. And that way we can outreach and get them the information. Back to the posters, we really made sure that we reached out to like grocery stores, laundromats, some of the motels where families are staying in a motel and paying daily or weekly. We're interested and let us put those posters up there. The food bank, family services, etc. Get those out where the population that we're looking to serve is at. The other thing is just the partnership with community resources is invaluable. If we didn't have that relationship with the shelters and the hub, we wouldn't be out there where we are just so easily accessible. For example, at the Men's Rescue Mission, our clinic area is right outside of the dining room. So they see us, they're by there all the time. We're visible, we're available, and I really think it helps the utilization of that program. This is another picture. This is actually on the right is our licensed addiction counselor, and then on the left is also the same person from the previous picture is one of our administrative assistants. and they're at the veterans event. You can see they went all out for the veterans and with the red, white, and blue, and then had some great giveaways available to them. And then they spend their time just visiting with them, listening to them, finding out what their needs are, and signing them up for services if they need services. This is that resource map that I mentioned. The map on the right, that is invaluable to them. They are always asking for this map, and other people hear about it and ask for the map. It just kind of shows them what's available in this Billings area, besides just our services. But shows them locations, gives them addresses and phone numbers, and then of course on the side we have our information, so they know when our clinics are available, and then they also know that they can come here to RiverStone Health, which is every day, and we're open till 7 in the evening, Monday through Thursday, and then till 5:30 on Friday. Plus we have providers on call at all times because our residents and our faculty providers do work in the hospitals, and so we have a doctor on call at all times, and that's very important for all of our population, for the Community Health Center and the Healthcare for the Homeless program. A second example of quality improvement in our Healthcare for the Homeless program, we're working to improve the quality, look towards excellent patient care. So we've developed our patient dashboard. This is a monthly report that we get per disease process. Right now, the one we're working on diligently is diabetes. So we get a list, and it's sorted by provider, and it lists every patient that provider has that has diabetes. Then it also lists when were they last seen, what their A1C is, what their microalbumin is, their LDL, their blood pressure, and the need for vaccines. What it allows us to do is look at that patient and look at what their needs are, and most importantly, you know, the first thing you look at is they really, a diabetic patient in our practice should be seen every 3 months. So if they haven't been seen, we need to get that patient taken care of. So that's what we work to do, is reach out to those people, see what we can do to get them in. The nurse will, or the administrative assistant, we have the whole team working on these, will contact the patient, for example, and just say, Mr. Smith, I see that you haven't been in to our clinic, and it's really important, you are diabetic, and we really need to see you to make sure that, that you're doing well. And then allow that person to talk and find out, why haven't they been in? What's the problem? Are they somewhere else? Is it transportation? I just talked to a gal the other day, she wants to come in, but she has no way to get in here. So that's when we step in with some other resources, and we can get them transportation to our clinic. We really encourage them to follow up. The outreach work and the case manager in this area with these dashboards with that Healthcare for the Homeless population are invaluable, because so many of them don't have phones. You know, of course, they don't have that permanent address. They may be at the shelter, but they may have been at the shelter when they were seen, but they're not at the shelter now. So these are the people that are out in the community, and they can look around and they can find them. They can look in the man camps. They can look in the other places that they may be staying. You see, you know, even if they're in the jail, wherever they are, they can help find them, and they can help work with them and say, you know, we really need to get your medical care taken care of. You know, how can we help you do that? The coordination and the care of those services through the whole RiverStone Health and all the programs is why we're having so much success with this dashboard. And then our community partners. I think that, you know, having a good relationship with your community partners is probably one of the most important things for you to just get out there and be available. In review, I think that when I went through the questionnaire on this project, I really think some of the things that we identified that could be why we were recognized is the access. The access for our, as I said, for our Healthcare for the Homeless patients, you have to be available when they need you and when they can get to you. I think it's amazing when we opened up access in the main clinic, the dental office here also opened up their access, which was awesome, because there was a time where Healthcare for the Homeless was always getting the dental care, but it was kind of like, okay, this is when it's available. And now it's like, what works for you? What works for you, the patient, so that we can serve you. And so that access is really, really important. The team-based care and the patient-centered medical home pathway, very, very important. We have the same providers. We look to always increase. We've increased our continuity by 17% just in the last few months. Patients at all clinics need to know that they can come in and see the same staff, the same nursing, the same provider. Now, if one of those isn't in place, we all know that happens, but somebody's there that's a familiar face that they trust and they feel comfortable with. We focus on the patient and their needs. Everything centers around the patient, and we work outward from there. Our care management and then ongoing quality improvement is always got to be part of the process. Everyone works to do it better, but if you can come up with a quality improvement process, we have forms you fill out, and it just helps you walk through it and always make sure it keeps you on track, that you are improving, you're always measuring, making sure you're doing what's best for our patients. That's it for me. I'll be here again at the end for questions, but I'd now like to hand the mic off to Marie Wisely at the Community Healthcare. Thank you very much.
Thank you, Carol. That was a great presentation. So, like Carol, our Community Health Center provides a lot of services that are available to our healthcare for the homeless patients. So everything that we have for the general population is available to them as well, and I think that's probably one contributing factor to our success as well. So today my presentation is going to be just a little bit different than Carol's. I'm going to focus on what our improvement program looks like at our organization as a whole. So when Sarah and I were talking about our good outcomes for our homeless patients as far as diabetes and cardiovascular are concerned, we were trying to pinpoint what do we think the secret to our success is, and I really just think it's having a very well-established, good quality improvement program in place. It's really the foundation that has carried our improvement throughout the organization. And we've been recognized by the Joint Commission and the CDC and now HCH for our improvement project. So I'm hoping that for those of you who already have a well-developed program, that maybe I can just give you a few hints to improve, and for those of you who need to start a good program, hopefully this will give you a nice overview and a little roadmap. If there's any questions beyond this presentation, I'm more than happy to answer them. You can email me or give me a call. So we will just jump into this. Quickly, just want to give you a snapshot of our clinic. Our clinic system has 9 locations, and we're by state. We have a range of primary care services and specialty services. I accidentally left dental off of this, so along with the infectious disease and chiropractic, mental health, health education, nutrition, we also have dental available as well. And then we see 40,000 unique patients, a little more than that each year, and that works out to be about 120,000 visits a year. We have 35 providers between our medical and dental, and we have over 280 employees. I'm not going to cover every single slide or all the information on the slides. I just wanted you to have everything I could possibly give you. So if I don't cover something and there's questions, please let me know. So one of the big questions I get is, what does a quality department look like? What should quality look like within a community health center? What should they be responsible for? So our purpose, what our department has been charged with is really continuously monitoring and improving the quality and safety of the services that we provide to our patients. That's first and foremost. We also want to minimize and reduce any kind of adverse outcomes. We want to improve efficiency, and of course we want to meet our external requirements for accreditation and any other state and federal regulations. So this is what our structure looks like. Because I manage both the clinical services and quality, it looks like we have a lot of people working towards quality improvement. They all contribute in their own way, but I do want to make the distinction that myself and the quality coordinator are really the only two people who are dedicated to that full-time improvement process. So under the quality umbrella, and this is going to look different at every clinic, I'm just giving you an idea of what it looks like here. I will say that having quality involved in all of these different areas has been invaluable to me. I think to have a really strong quality improvement program, you need to understand how everything works. So of course we're responsible for the improvement program itself, developing the plan, implementing it, and then obviously maintaining it throughout the year. We also act as internal consultants, myself and the quality coordinator. We help guide staff to selecting improvement opportunities, assembling their teams, collecting baseline data, helping them perform tests, measure their results, and then communicating those results as well. Data management, we are a very heavy data-driven organization, and when I first got into this position, we had the DRIP going on, which is the data rich and information poor. So we really needed to come up with a way to standardize how data would be selected to track, how we would monitor those, how would we develop plans for data management. As we all know, community health centers have short on resources, and so if you collect everything, you're not going to improve anything. We also make sure that the data collection is timely, because we don't do all the data collection. I think it's important for the departments to do a lot of that themselves. So I just listed some major responsibilities, and won't go through everything. I wanted to highlight a couple of things. I am responsible for working with the medical and dental directors and our program directors to select clinic-wide priorities. That is really sitting down and looking at what does HRSA require us to do, what do we need to do for UDS, what does Healthy People 2020 want us to do, and then really looking at what does our patient base need. And based on those factors, we come up with the clinical priorities. Grant expectations, I think it's important to note that not every grant is appropriate to take because it's money. Sometimes the return on the investment is not always where it needs to be. So part of what we do is evaluate each grant and say, yes, we're getting $3,000, but it's going to cost us $8,000 to collect the data. So it's important for us to be in on that. We also try to align what our current improvement priorities are with any grants that we take on. Infection control also falls under my responsibility, patient satisfaction, policy and procedure development. We don't actually develop the policies, but what I felt like was missing was there needed to be one person, which is me, who reviews all policies to make sure that they comply with any regulatory requirements, Joint Commission, patient center, medical home. We also provide all the training and education to the staff regarding quality improvement, interpreting data, how to analyze data, infection control, and regulatory standards. And then, of course, we have our Joint Commission accreditation. Unusual occurrence and patient complaints. I also review these to make sure that the organization is not put at any kind of risk, that we followed up appropriately, that the patient complaint was resolved the way that it should be. So we're just going to move right into what our program actually looks like. So of course we decided when we started this program 10 years ago, we really needed to have a standard organization-wide approach to quality. Before that it was sort of willy-nilly and people were using different methods and really wasn't coordinated. So that's the first step. And then the next thing is we really wanted to develop this culture of quality, not only within our staff, but our providers, anybody who comes in contact with the patient. So we really put quality front and center, not only when we're recruiting staff, but during orientation. So the interview process, we talk about what our program looks like, what our clinic priorities are, and let them know that they will have individual responsibilities in quality improvement. Also, annually, we rank employees, including providers, based on their participation in performance improvement projects. We offer a small monetary incentive for staff who participate on internal committees. And then a portion of the provider incentive is tied to patient outcomes. So there's actually a quality incentive along with productivity. One thing I feel like is a double-edged sword and we're good at and still always need improvement in is the communication. So one strong principle for me is that I feel like you can never over-communicate enough. So I actually physically attend every provider meeting. We review patient outcomes. We look at the data individually. We, as a group, decide we're not where we need to be. Let's start to get an improvement project moving. Who needs to be included? What are our goals going to be? We've also developed monthly and quarterly reports for our providers that will show them how they are performing individually against every indicator, what they look like compared to their peers, and how the organization is doing as a whole. All of that is now available electronically, which is going to be great. Also, I want to emphasize that our CEO and medical director and dental directors are very committed to quality. They don't always agree with everything we want to do, but they know that it's the right thing, and they support us 100%. So the CEO and medical director and dental directors actually review the provider progress for patient outcomes towards their goals annually. And if a provider is not meeting goal, there needs to be an action plan in place. Just some other communication things we do. We have an internal committee, which I will talk about in a few minutes, and that committee is responsible for communicating any projects, anything that we're doing for performance improvement. We do that through a newsletter, and then those committee members actually go out in person, go to all the different department meetings, and talk about the current improvements we have in place. So the methodology, which I spoke about earlier, we needed to choose something, and there's lots of things out there. There's PDSA, there's all kinds of stuff. But we felt like we needed to have an objective way to start solving our problems, and it needed to be based on data rather than hunches, and of course we always want to use our resources efficiently. So we chose the DMAIC model, and what I like about this model over some others is there's a real emphasis on the control piece of it, so sustaining those system improvements. Another thing we do is there's improvement requirements for every department manager. So they need to have a PI project going in their department every single year. And then we have organization-wide performance improvement projects for the whole organization. And those are selected by that internal committee based on patient outcomes and data from the previous year. It's sent up to our leadership, and we approve those, and then it moves on to the board of directors. So every person that's directly involved with our organization understands what our improvement priorities are. So with that said, now we have created a culture where everyone's bringing projects to the table. And so we need to come up with an objective way to sort of sift through these and make sure, one, is it really a performance improvement project, or is it a employee issue that needs to be taken care of on a different level. So we have a matrix that we go through, and we look at things like how likely is this project to improve patient outcomes, how is it connected to our mission and strategic goals, will it improve a key process, what's the financial impact, and how feasible is the project. Someone may have the best idea in the world, but if it's going to cost us $10 million to implement, there's no way we can do that. So any improvement projects, and these are for the organization-wide, anything we're going to put our resources towards needs to score a 15 or higher. Project oversight, there's a couple of different ways that we make sure that projects continue and there's that control phase. One is the teams themselves who are working on the improvement need to report up to our internal committee. That internal committee reviews those results on a quarterly basis. They then report up to leadership, and then I report to our board quality improvement committee. And this is all done on a quarterly basis, so everyone's held accountable along the way. Data management, again, we're very data-driven here, and so we do have a data management plan that covers a multitude of different things, clinical, financial, operation, as well as patient and staff satisfaction. We use these dashboards every month to help us plan for the future, make decisions, and the internal PIQI committee also reviews these dashboards on a quarterly basis as well. So again, measure selection is important. I think I spoke about when I first joined the organization and data was being collected all over the place, but we weren't really utilizing it well. There needs to be a return on investment for your data that you collect. That effort that you put into it needs to pay off in the end. So we really prioritize our data. It needs to have a significant tie to patient health outcome satisfaction. Again, it needs to align with our strategic goal, mission, vision. It could be tied to a regulatory requirement or have a financial impact. So we just can't measure everything. So we are very selective about what we measure. So I'm going to talk about our internal performance improvement committee. It is led by our quality coordinator. Staff from all departments and clinics and programs participate on this committee, and they are charged with communicating a single organization-wide customer-driven approach to all of the staff. They need to get that message out there. They're also responsible for making sure that all of the indicators and measures that we look at, that they're moving in the right direction. If they're not, it's their responsibility to make sure that there's an action plan in place, and we give them the authority to do that as well. We also have a board quality improvement committee, and this is made up of board members and community members, and anything that we've selected as a priority for the organization moves up through this committee, is reviewed, and then that committee recommends to our board of directors. So we make sure that they're fully informed of all of our improvement projects, any data that we're collecting, any issues that we might have with unusual occurrences, any of those types of things. They really do sort of keep us focused on our established goals. They also approve our organization-wide improvement plan, which we update every single year. And there's, okay, so challenges. I know it sounds like everything is sunny and rosy over here in Davenport, but it is not all the time. It takes really hard work. I think I liken it to a marriage, that you need to really work at it to make it work. So we have lots of challenges here, same challenges you all folks deal with. We have turnover. You just get somebody settled, trained, get them involved in performance improvement, and then their spouse gets transferred and they move. We have providers who've been wonderful champions and they want to go into a fellowship. So turnover is always a challenge. Technology has been a challenge for us. We recently implemented an electronic health record, which has been wonderful, but when the technology doesn't work the way that it's supposed to, it can easily deter staff from moving along the improvement path, and sometimes they'll slip back to their old ways. So where I once thought, oh, once we automate this record, this is going to be wonderful, has presented some challenges. Competing priorities, I'm sure all of you can identify when you receive funds from the federal government, or you are accredited by Joint Commission, or you're going for patient-centered medical home, the priorities are changing almost daily about what's important. So we really try to teach our staff from the beginning that they need to be flexible and they need to find ways to change with those changing priorities. We don't sugarcoat anything. If someone can't deal with change, it might not be the best place for them, because you're never going to feel like you're accomplished, because things change constantly. Also resources, and I'm sure all of you deal with this as well with being a community health center. We live paycheck to paycheck, and it's important for us to utilize all of our resources appropriately. So that is the end of my presentation. Again, if there are any questions that pop up after this, I would be happy to speak to anybody on the phone or help anyone out. So please don't hesitate to ask. So I am going to hand the mic over to Sarah.
Great. Thank you so much. Thank you to both of our presenters, and we're going to now begin our Q&A session. I'm going to throw this first question out to both presenters. It is, with the promotional activities potentially increasing volume of patients seen, is there an impact on the quality of care? Are indicators of quality still met?
This is Marie. I'll go first. I think there's always an impact. I'm not sure that it's an increase in patients that we can't handle. I think once you get a good process in place and you continue that, and as long as the supply and demand is at least, somewhat balanced, where we see quality slip off is when we have providers leave the organization and a new one comes on, and they have to get used to sort of the way we do business and the clinical practice guidelines here and everything that they need to document. So that seems to be the biggest challenge for us.
This is Carol. I agree with Marie. I think that one of the biggest challenges is if you do lose, especially for us, a full-time provider in our clinic, that's a big loss. Because we work with the Montana Family Medical Residency, every year we have our third year residents graduate and new interns come in. So that kind of turnover we're pretty used to, and we've made that a more seamless transition. But it is still difficult. As far as more demand and more patients coming in, as much as we've worked in the main clinic community health center, decreasing our no-show rate from 22% to as low as 10%, there really are still appointments available every day that will not be used. So, hopefully we'll be able to continue to meet the demand and continue to grow. And truly looking at using clinic when clinic's not open. You've got evening clinic, you've got weekend times, so that's where our expansion will take place as our number of patients grow.
Okay, great. Our next question is for Marie. Marie, are incentives just for the provider or the entire care team?
The incentive comes a different way. The bonus that is tied to the providers that was all based on productivity before, those quality indicators or that incentive for that is just for the providers. The staff get the incentive through participating in projects or participating on a committee. We are looking at a new structure that would include the staff to get monetary incentives for the outcomes that our providers are responsible for with the patients, because as we know, it's really the nursing staff and ancillary staff that get the patients seen, so they very much contribute. So we are looking at a couple of different possibilities.
Okay, great. Marie, another question for you. Any examples of how the QI program has improved your care to the homeless population? Looking for specifics and interested in aha moments related to the homeless that were learned through the QI process.
Yeah, I think I do. I don't have our numbers in front of us, but a couple of aha moments we had. Our homeless site is actually located not within our main clinic. It's only about 6 blocks up the street, but we were not offering the services of this, the main clinic to the homeless clinic. And so I think once we got a better tie of what their patients needed, then we started to move those services up to them. So anything we could do while they were there, we did. And that was sort of an aha moment for us when we started to sort of dissect how the care is delivered to our homeless patients. So we now store vaccines up there, and we will send a phlebotomist up if we need to. We'll get them transportation down here to get their their labs or their x-rays if they need them. So I think it was sort of unfortunate that we had all of these resources just a few blocks away, but it never occurred to us that somehow that might be difficult for our homeless folks.
Okay, great. This next question is for Carol. Carol, what are some ways I can initiate a culture change toward QI at my clinic? Our quality program right now is fairly limited.
I think when we tried to change that culture is when we did we started meeting on a regular basis, and we had a tool. We do use the PDSA, and then we got our staff. The next step then was to kind of get all the leadership to, like Marie said, get it on paper and make sure it is measurable, make sure it's worthwhile, and it will make a difference for our patients. And then we really work to involve the staff. It's easy sometimes to get busy and just kind of do the work, but if the staff buys into it, they help identify those problems, and then they help gather the data and come up with ideas for change. For example, with the outreach, I mean, the staff has been the one to say, you know what, those brochures you guys made, they just don't work. We need the map. Remember the map we had years ago? And so, you know, we dug and dug until we found that darn map, and we've got it back into place. So just I think getting everybody involved.
Okay, Marie, do you have anything to add to that?
For us, it was about communication and feeding back the information to the providers. I think that really started to build our culture of quality, and you can do that in any setting. You don't have to be a big organization to do it. But once we started to sort of compile, and we used to compile all the results with hand audits and putting things into spreadsheets up until about 6 months ago. So you can do that, feed the information back to the providers, get them together, talk about improvements, review how the data is collected. I think also having a really good data management plan will help sort of build that culture of quality, because before that, we would really get stuck with the providers when they started to question us on our methods of collecting data. You know, I'm not a statistician. I believe in the performance improvement model where you collect data to figure out sort of where you're going and then make small improvements from there. So I think we needed to be a little more sophisticated with that. But I think communication. And the other thing that we did was we compare our providers to each other. So Dr. X can see what he looks like compared to his peers. Now, the peers are blinded, but that really did spur on sort of that competition piece as well. And we expect them to participate in performance improvement. They sit on teams, they have jobs, they need to participate. So you can't leave them out of the quality improvement process.
Okay, awesome. This next question is for Marie. Marie, how was your experience implementing your EHR? You kind of touched on that earlier.
We actually had a really good experience. We did so much planning on the front end, and I don't know who asked the question, but we have an electronic health record coordinator, and if you would like to speak to her, I'd be happy to make that introduction, and she can talk through. But basically, we set up one big committee and then had subcommittees from there, and the subcommittees would consist of hardware, templates, meaningful use measures, and providers participate on that as well. So I think having people involved who were going to use the equipment, the providers got to choose which equipment they were going to use. They tested iPads, they tested laptops, they tested in-room equipment, and they got to choose. So I think having that input really got their buy-in. We also implemented gradually. We started at one clinic, and then once they were fully implemented, then we moved to the next clinic. We also had 3 people who were clinical and who are super users that would break out providers and nursing staff into small groups and provide one-on-one training. Then for 2 days, the providers would have one of the trainers with them. They would go in the room with the patient. So really our productivity did not suffer much. I think it was the first clinic was back up to full productivity within 4 weeks. So our experience has been good. There is some complaining, I think, from the providers that we've also did abstracting ahead of time. We did not expect our providers to do abstracting or nursing staff. So we hired temporary staff to pull out significant information that the providers ahead of time agreed these are the things we want abstracted in the electronic health record. So I think budgeting for it, understanding there might be a loss, really planning for it, we had a very good experience.
Okay, great. This question is for Carol. Carol, what caused RiverStone to open access? What exactly spurred that decision?
I think probably just the fact that, looking at, as a QI project, looking at, why is your no-show rate so high? Number of empty appointments. You're always looking at any feedback or survey feedback that patients give you. And then the pathway to patient-centered medical home access is a huge issue, a huge tenet of that. And that has just been the most successful, if I could say, along with the electronic health record, that access, accomplishing that and improving that, and we'll always be working to improve it. I don't know that we have the perfect answer on it, but what we're doing right now is working well for us. But that is probably one of the best things that we have done is increase that access. But truly was a QI project and then also patient-centered medical home.
Okay, great. Well, I think that concludes our question and answer session. Thank you so much for your questions. They were great. I want to let you know about a few resources that will be available on our website. Coming soon, you'll be able to access the full version of the Quality Leaders case study on our website at www.nhchc.org. And then also, in the coming months, we'll be publishing a Quality Leaders Quick Guide, which will contain practical tools and resources to track and improve your health center's quality of care. So please do keep an eye out for those publications. I'd like to thank you all for joining the Quality Leaders webinar produced by the National Healthcare for the Homeless Council. Also, please visit the NHCHC website for a listing of upcoming council webinars and other educational products. Thank you so much for joining us, and this meeting will now be closed.